Hello, my name is CDougherty and I'm a professor in the Department of Biobehavioral Nursing and Health Systems at the University of Washington School of Nursing. And I'm also an adult nurse practitioner in the Department of Cardiology and Electrophysiology at the Seattle VA Medical Center in Seattle, Washington. And today I was asked to talk with you about a couple of things related to using and creating evidence for clinical practice. The patients that I am more involved with than any other are those with advanced heart failure, and specifically those patients who have suffered cardiac arrest and have received an implantable cardioverter defibrillator. And the importance of this work, at least for those in the U.S., about 1 million or more people are living with advanced heart failure and defibrillators right now in the United States. And in nursing, we are interested in creating programs that improve patient outcomes, specifically those programs that have to do with improving patient responses and living successfully with chronic health conditions. And so our work directly is related to those goals. There are two things about creating evidence I'd like to talk with you about, and then secondarily about how we're using evidence from clinical practice guidelines in our current work. So right now we have two funded research projects at the University of Washington to help create new evidence for practice. The first research study has to do with testing moderate to strenuous exercise interventions in people who have a cardioverter defibrillator and helping them begin and sustain exercise programs at home without fear of having cardiac arrhythmias or experiencing defibrillator shocks. And that particular project right now is in the translation phase, where we are just now creating new projects to move evidence we created from research into clinical practice. And that would be labeled as a T2 translation study. The second example of creating evidence for practice is we're testing a new patient and partner nursing intervention that helps both patients and their intimate other significant partner to adjust successfully to living with an ICD by improving quality of life and reducing fear and their confidence to deal with issues related to managing heart symptoms and managing fear of getting defibrillator shocks. And we are just in the final year of data collection on that study, and hopefully when the study's finished, we'll have a package of interventions that can then be taken to clinical practice to improve both patient and partner outcomes. And the second area I wanted to speak with you about today is using clinical practice guidelines that are already published in the literature to bring those practice guidelines to practice. And there's two examples that we're doing right now in our practice at the Seattle VA. One is to bring the practice guidelines that were developed by the American Heart Association and the European Cardiovascular Committee to help providers determine how to manage defibrillators and pacemakers when patients go to surgery or have invasive procedures that would perhaps involve electrical cautery interfering with device functions. Those guidelines were published in 2012, and we've instituted new programs at the VA to make sure that our work is up to date with those clinical practice guidelines. And the second area of bringing clinical practice guidelines to the clinical area has to do with the management of pacemakers and cardioverter defibrillators in patients who are at the end of life. And the clinical practice guidelines that were published in 2012 show us new algorithms to help us successfully manage cardiac devices at the end of life so that patients' quality of life is enhanced as they enter new phases or end-of-life programming and symptoms towards the end of their life. So thank you for this opportunity to speak with you today about our research, and I hope that this gives you some ideas of how you might be able to bring evidence or use evidence in your practice.